Good afternoon and welcome to Neuromodulation Techniques Used to Treat Atypical Facial Pain, featuring Dr. Ashwin Ramaya. I'm Sarah Winner, Marketing, Communications, and Events Manager for the Facial Pain Association. Welcome, Dr. Ramaya. We're so glad you're here with us today. So a couple of housekeeping items before we get started. Attendees, you have some features on the right side of your screen, chat and Q&A. So the chat is for attendee conversations and connections. The Q&A is where you want to submit your questions for Dr. Ramaya. So we'll go through his presentation and then we'll have time after where we can ask as many questions as possible. So speaking of questions, please remember that Dr. Ramaya cannot answer any specific questions about your case or your situation. So we're going to try to generalize the questions so they're most relevant to majority of the people. So with that being said, we're going to continue. I'm going to introduce Dr. Ramaya. He is an assistant professor in the Stanford Department of Neurosurgery. He specializes in neuromodulation, including deep brain stimulation, spinal cord stimulation, MRI-guided laser therapy, and focused ultrasound. Dr. Ramaya obtained his MD and PhD from the University of Pennsylvania, where he also completed his neurosurgery residency and a fellowship in stereotactic and functional neurosurgery. Dr. Ramaya has been published in numerous peer-reviewed journals and has presented his work at national and international meetings, including those for the American Association of Neurological Surgeons. So without further ado, Dr. Ramaya.
Thank you so much, Sarah. I really appreciate the introduction, and thank you so much for the opportunity to speak here at this really amazing conference. The title of my talk is Neuromodulation Treatments for Atypical Facial Pain. As Sarah said, I am a assistant professor at the Department of Neurosurgery at Stanford. I just want to say that I have no disclosures and no conflicts of interest. So the brief outline for the talk, which I want to be keep very high level and really focus on the overall concepts and where we've come from and where we're going. But the first goal is to define typical and atypical facial pain. Second, highlight challenges involved in treating atypical facial pain. Third is generally speak about treatment strategies for atypical facial pain, including a discussion of what the past, the present, and the future. And specifically, we're going to focus on two distinct treatment strategies, and that's brain stimulation and brain ablation. So first, I want to start off by laying out one way to define typical and atypical facial pain. So first, typical facial pain, which is often also referred to as classic trigeminal neuralgia, type 1 trigeminal neuralgia. This definition involves a focus on how the pain presents. So this involves facial pain that's localized and located to one or more facial distributions of the trigeminal nerve territories. It's typically unilateral. A very defining feature is the timing of it. This type of pain involves sudden, intense electric bursts of pain that are very brief, typically last from a few seconds to less than 2 minutes. It can be triggered by various innocuous stimuli, various maneuvers such as talking, gentle touch, wind. And then the key thing is this type of pain generally shows a very good response to surgical treatment with microvascular decompression. So in the figures here, I'm showing from a very nice review paper in the New England Journal of Medicine, typical areas that are identified as locations for typical facial pain, trigeminal neuralgia. And then the underlying cause is believed to be the compression of the nerve root, the trigeminal nerve, the sensory nerve as it enters the brainstem by a vascular structure, either an artery or a vein. And so if medications aren't successfully controlling the pain, and the pain continues to be disabling despite trialing several medications, a favored therapy is surgical treatment with microvascular decompression, which you've heard about in a separate talk. And this involves separating out the insult, the causal insult, which is the vascular structure, from the nerve itself. And that has been shown to be very effective in patients who present with typical facial pain. However, atypical facial pain, often which is called by many different names, but another one that is described in the literature is persistent idiopathic facial pain. This we can define as facial pain that involves trigeminal nerve distributions, the same territories that we're talking about, but in a more irregular pattern and can sometimes be bilateral. It does not show the typical features that I described earlier that are used to define typical facial pain. And the key thing is it's highly variable and heterogeneous across individuals. And it also shows a poor response to microvascular decompression and other standard clinical treatments. So thinking a little bit more about this distinction between typical and atypical facial pain, and recognizing that there are many other ways to go about defining atypical facial pain, such as Dr. Burchell's categorization that involves patient history. Here, we can break it down simply into thinking about what the cause is, right? So in typical facial pain, as I described, the cause is thought to be a vascular structure that's pressing or intermittently compressing the trigeminal nerve root as it enters the brainstem. And that structural problem causes a change in how the brain is working, and that change in how the brain works is causing the experience of pain that causes suffering. This general idea or explanation has a lot of similarities to very early ideas of what pain is that were initially suggested by René Descartes in the 1600s, where there's a very clear causal link between the outside world, such as fire, that then is sensed or detected by sensors on the skin, and that message gets transmitted up into the brain, and that causes pain and suffering. However, it's clear that that is not the case in many forms of pain. And in some forms of pain, it's not the cause is not coming from outside the brain, but the cause is actually happening within the brain itself. An analogy I like to draw to patients that come to clinic is thinking about an alarm system. When you have an alarm system, which is what we think of, which we can think of pain, the pain system as a way to keep the body away from danger, such as a fire. The goal of the alarm system is to detect danger outside, and then outside the brain, outside the body, and then identify, set in motion a series of behaviors that can that can be protective and that can keep us safe. However, in some cases, the alarm system itself begins to malfunction, and that alarm system is what the problem is, and that alarm system can cause suffering in itself. And in the case of atypical facial pain, you can think of the way the brain networks are processing signals from outside the world, particularly from those sensors that are involved with interpreting signals from the face. That malfunction is the actual cause of the pain. It's not something outside the brain, but something inside the brain itself. Now, this is quite challenging because unlike structures that we can localize to a specific physical space, the brain is highly complex and can malfunction in many different ways. And so the way each individual patient's pain presents can be highly variable. And it isn't fair or realistic to actually think about typical and atypical facial pain as two separate buckets where patients can individually be classified or neatly be classified, but rather the reality is probably more close to a spectrum or a lot of overlapping types of facial pain that can sometimes even include features that include both typical and atypical features. But certainly it's not the case where there's a a single explanation for every patient's facial pain. So just to summarize and crystallize this point, if we think about the challenges in treating atypical facial pain, it boils down to understanding the cause. And the cause of atypical facial pain, we think, is coming from the brain networks themselves and how they are interpreting signals from outside the world, the way in which the alarm system is functioning, not the actual presence of an external factor that's causing the pain. And the first challenge is that the brain is highly complex. It's a very highly complex system and can malfunction in many ways. So even though we can say that the cause of atypical facial pain comes from the brain, what that specifically means for an individual patient can be very, very different. And so that's what challenge 2 is. Because the brain can malfunction in so many different ways, it means that each patient's disease is unique and requires personalized treatment. So when we think about treatment strategies generally for atypical facial pain, there are two general strategies that I'm going to discuss. So one is brain stimulation, and this involves using electrical stimulation by placing electrodes inside the brain or on the brain surface that are aimed at altering dysfunctional brain circuits with the hope of improving function. So in the case of facial pain, the goal would be to try and introduce electricity near structures that are dysfunctioning and where the alarm system is malfunctioning and causing suffering. And the goal would be to use electrical stimulation to change the way in that alarm system is malfunctioning and reduce the experience of pain. An alternative method is something called brain ablation. And here is to use various techniques, and I'll speak about one in the next slide, that are aimed at actually disrupting the neural circuits, or by causing an ablation or a destruction of a very small part of the brain circuit, so that the alarm system can be short-circuited, if you will. It can disrupt the way in which the alarm system is actually sounding, making loud noises and causing suffering, right? So in general, if we think about the two strategies, one is to use electricity to alter the function of the brain, and two is to use energy, other forms of energy like heat, to disrupt specific parts of the brain circuit and change the structure of the brain networks and improve pain. So the reasons these strategies are promising is that they've shown to be very effective in the treatment of movement disorders. And I'm going to speak about one example here. This is a focused ultrasound, MRI guided focused ultrasound. So this is a very new technology. It's emerged over the past been in development for the past 20 years or so, but it was FDA approved for the treatment of essential tremor in 2016. And in this technology involves using focused ultrasound transcranially. So it does not require making an incision in the skin or an opening of the skull, but rather just focuses thermal ultrasound energy into very specific brain structures deep in the brain. Here, the focus target is a specific part of a structure called the thalamus. And by targeting ultrasound energy in that area, it generates heat, and that heat can cause a burn, and that burn can change the network of the brain and the way that the brain is processing information. And when applied to a specific therapeutic target, it can dramatically improve function. So in this, here with essential tremor, this is an illustration of that for one patient. So essential tremor involves an inability to form smooth movements. And so here on these spirals, these spiral templates, the patient's asked to draw a smooth line following the spiral that's illustrated here. And so at the beginning of the treatment, the patient's tremor is so severe that they can't apply pen to paper and draw a smooth line. Now, over the matter of hours, as the thermal energy accumulates in this one specific region of the brain, the tremor begins to improve, suggesting that the brain network is changing in a way that is improving the disease, right? So the patient starts out by not being able to draw smooth lines, but as the treatment goes on, the spirals get smoother and smoother and smoother. And now this focused ultrasound for central tremor, building on a long history of prior work using other methods to make lesions in the thalamus and brain stimulation of specific parts of the thalamus. It's FDA approved, and it's shown effective therapeutic efficacy for up to at least 5 years now. And we're still continuing to understand the long-term benefits. And there's also a very favorable safety profile. The reason I bring this up is because this shows promise that the technology that we have now with brain stimulation and focused ultrasound allows us to change the brain in a way that can potentially improve certain diseases. Now, unfortunately, with chronic pain in general, and certainly specifically atypical facial pain, prior studies have tried to use both lesion ablation and brain stimulation at various sites, various parts of the brain circuits that are thought to be involved with pain processing, but the results have been fairly inconsistent. Many patients don't respond to treatment, although some do, some show benefit. We don't have a very good way of predicting who's going to benefit and who's not. And another major challenge is that it's treatment, the benefit that is often seen early on starts to fade away over time. And it's there hasn't been the demonstration of high quality evidence supporting these treatments for atypical facial pain that show long-lasting efficacy with a favorable safety profile. But that's the goal. That's our goal right now, and that's the work that we are beginning to do here at Stanford and at many other sites, is to leverage tools and methods from neuroscience and emerging techniques from neurosurgery and neuromodulation to be able to develop a new approach to treating atypical facial pain. And that begins with understanding the cause of each patient's facial pain, each patient's pain, at a personalized level. So rather than coming up with attempting a one-size-fits-all treatment, whether it's brain stimulation or ablation, the goal would be to map out each individual patient's disease in the context of specific brain structures, and then leverage techniques which allow us to study the neural activity and at those distributed regions and potentially test the effects of brain stimulation in a temporary manner to identify whether or not there is going to be benefit for an individual patient, and then ultimately tailor a specific neuromodulation treatment, which involves either brain stimulation or focused ultrasound that can be specifically designed for each patient's disease. Now, we are very early in our efforts right now and are doing are in the process of establishing clinical trials, doing feasibility studies, so on and so forth, that can hopefully make this a reality. So this is very early still in certainly in what we are doing, but we are certainly interested in moving this forward as safely and effectively and quickly as possible. So I want to say that I'm part of the Stanford Facial Pain Program, which is led by Dr. Michael Lim, Meredith Barad, and Dr. XQ. We also have my partner, Dr. Vivek Butch, who is going to present along with me, but unfortunately wasn't able to be here today. But in general, together, we're, as a team, interested in providing comprehensive care for patients with facial pain in general. And our goal, particularly Dr. Vivek Butch and my goal, is to develop these very personalized, tailored neuromodulation treatments for atypical facial pain. I've included some reference here, but at this point, I'm happy to take questions.
Thank you, Dr. Ramaya. We actually do have plenty of questions for you, so we will put the first one up. Do previous MVDs impact the success rate of neuromodulation?
That's a very good question. I think the goal is to develop treatments that can account for how the brain may have changed after a previous MVD. So I've seen certainly certain patients in clinic who have had a particular pattern of facial pain and then undergo treatment. And unfortunately, the treatment is not able to help their pain or causes a new type of pain. And that suggests to me that the brain is different after the treatment than it was before. So the approach that we are working towards is to try and incorporate how the brain has changed after treatments that have not been successful in the past.
Great, thank you. Next question. How successful is neuromodulation for anesthesia dolorosa?
That's a very good question. Anesthesia dolorosa has been specifically a focus for neurosurgery in the past, and prior studies have shown fairly inconsistent results based on sort of standard approaches, where there's about 50% chance of benefit early, but then that really declines over time. So, however, I do believe that anesthesia dolorosa is a really very compelling focus or compelling indication for personalized treatment. There's typically a clear inciting factor, inciting event that changes how the brain is interpreting signals and starts to conflate numbness with a feeling of pain. And that suggests that there is a way to identify exactly when and where that the brain changed and develop personalized treatments. But certainly it is just as challenging as treating other forms of atypical facial pain.
Great. Next question. How do you differentiate between post-traumatic trigeminal nerve pain and centralized atypical facial pain from a neurology standpoint?
I think that gets to the heart of what we're trying to figure out here. So most of what we do is try to classify patients based on symptomatology, history, so on and so forth. And it's very difficult to draw lines between, for example, in this case, post-traumatic trigeminal nerve pain versus centralized atypical facial pain. And when we do identify methods to distinguish between these criteria, they're based on some arbitrary rule, whether that's a historical event, something that's happened in the past, or some particular symptom that the patient is reporting. But ultimately, it will require understanding how the brain is malfunctioning, or how the entire nervous system is malfunctioning to generate the particular type of pain. I think that level of understanding will allow us to tailor treatments, will be practically beneficial, so it will allow us to tailor treatments. Now, there is maybe more we can learn about how specific terms that the patient uses or specific modifying factors may be indirect measures or indirect indicators of the underlying cause. And certainly that seems to be a useful source of information to identify typical versus atypical facial pain, right? Because it has been generally helpful in identifying patients who will improve with the microvascular decompression. But it's imperfect. And I think there's going to be patients that maybe meet typical criteria, but maybe have atypical causes underlying that are underlying the symptoms. So short answer here is it's difficult to currently, and that's a major goal of the research program.
Great, thank you. Dr. Ramaiah, what are the possible side effects with neuromodulation techniques, treatments?
I think that's a very, very important question. I haven't specifically talked about them because it can be very variable depending on the treatment, depending on the location of the target, and the method that is used to modulate the brain networks or modulate the brain in general. But I'd say when we think about deep brain stimulation, it involves making an incision in the skin, inserting electrodes into the brain, and then turning on electrical stimulation. Now, there's general side effects associated with bleeding, infection, pain, the need for another surgery. The one big advantage of deep brain stimulation is if it causes side effects such as weakness, difficulty speaking, worsening pain, you can turn off the stimulator, and that can sort of manage some of the side effects that are caused by the electrical stimulation itself. However, it wouldn't be able to reverse or undo side effects associated with placement of the electrode itself. Now, focused ultrasound, which is sort of one method of doing brain ablations, there's some very unique advantages because it can be done without actually making an incision in the skin or physically penetrating superficial brain tissue, but you're rather focusing energy transcranially through the skull. Now, so there you don't have the risks associated with bleeding and infection and pain, or very rarely. However, when you do make the change in the brain, it's hard to go back. You just have to wait for the brain to recover. So if there are side effects such as weakness or numbness, or difficulty speaking that are caused after focused ultrasound, it's something that you'd have to wait for the brain to recover. And in most cases, those adverse effects are transient. The larger point here is to weigh cost and benefit. So whenever we think about invasive treatments, we really, really want to think about them within the context of less invasive treatments, which are generally safer, and making sure that there's still disabling pain despite exhausting all available non-invasive treatments.
Great, thank you. Next question.
Yeah.
Would
yeah.
an effective treatment to start before something invasive?
Certainly, I would recommend TENS unit is something that has extremely low risk of harm. And I hope the one message that came through with the presentation is one of humility and recognizing that we still have a long way to go before we can understand the pathophysiology here and understand the cause and for each patient's pain. So certainly, I think there have been many cases where interventions such as TENS unit can be beneficial. In many cases, it's not, but it's certainly worth.
Okay, great. Thank you. Next question. If there is a TM compression via artery, yet there is background pain without electrical zaps, would you refer to this as typical or atypical?
Yeah, this is one which I would place in that middle ground between typical and atypical, right? So there are some features that suggest a typical cause because there's the compression via the artery, but the presentation suggests that it's not typical, that it's not episodic in nature, and may suggest that the pain is not being caused because the artery is pressing on the nerve, but it's caused because the brain itself has now changed, right? So this is something called centralization. It's a process by which the brain adapts to this chronic experience of pain and starts to sort of simulate it, if you will. And so this is exactly the type of situation I would use to support this idea that there's not clear buckets between typical and atypical pain, but rather each individual patient it sort of falls on some spectrum between the two, and it is critical, absolutely critical, to understand each patient's disease on a personalized level.
Okay, thank you. Next question. Does this work for glossopharyngeal neuralgia patients and those with vagus responses symptoms? Do you need participants?
Certainly, it is not specific to any. The general approach would potentially be applicable to a wide range of chronic pain syndromes, not just a specific facial pain distribution. So certainly it's possible that we would be able to develop some treatment strategy for glossopharyngeal neuralgia and with autonomic dysfunction. Certainly the place to start, which is where we are, is understanding the pathophysiology at the individual patient level. And for that, we certainly are interested in recruiting participants to volunteer in the preliminary studies, and that those studies would not involve any risk or harm. That's simply doing brain imaging and understanding patient-specific symptomatology and descriptions of their pain, so that we can begin to classify and understand the pathophysiology underlying each patient. So yes, we certainly are interested in working with you to help work towards developing treatments.
Okay. So just a follow-up question, what's the best way to get in touch?
I think so the Stanford website, the facial pain website, which I can share the link, has information on how to contact us. And one service we offer is a meet and greet, where even if you're out of state or out of the country, we can set up a Zoom meeting in a video conference and just have a conversation about where your pain fits in and to the larger spectrum, and where you are in your journey, and how we can potentially help you in the long term. And certainly that would also enable us to follow up with you, hopefully when we have a clinical trial that we are recruiting patients for, if your pain presentation, your characteristics meet criteria.
Great, thank you. So can you please discuss neuromodulation techniques for geniculate neuralgia?
I haven't seen much literature on that. That maybe just I've missed it, but I don't have any specific literature that I can refer to thinking about neuromodulation for geniculate neuralgia. So I'm certainly happy to follow up later if I can find anything, but I don't have anything right now to speak to that specifically.
Okay, great. Let's see. Are there any studies that can be provided to insurance companies to indicate that neuromodulation is not experimental?
That is exactly, that's a very, very, that's a big challenge for patients who want treatment now, is being able to get this approved. There's emerging literature, but certainly happy to follow up and share some of the studies that I would find, but I suspect that they're not going to cut it. I think that's what the field is waiting for, is some class 1 evidence showing long-term benefit, and we're still waiting for that. We're still working towards that. There's certainly promising signs and smaller studies that are showing positive results. However, there's insurance companies can be very, very specific about what they're looking for to approve a claim.
Got it. Thank you. All right. What would be the preferred or recommended implant stimulator for AD?
I think that's an open question. There have been specific targets that have been the focus of prior efforts, but it's certainly very possible that for each individual patient, they have therapeutic targets that are unexpected. So I do think it will involve keeping an open mind on what the target is for every individual, and working towards identifying that target, both by brain imaging and trial neuromodulation.
Very great. Have you experienced success with neuromodulation reducing pain that emanates from the eyeball?
I have not. Again, it's just, I think of this all as different manifestations of some underlying change in the brain. Once you rule out the fact that there's a peripheral cause that can be addressed, such as something compressing a peripheral structure, at that point it's about identifying where exactly the pain signal is being generated in the brain, and it's probably not in a single spot, which makes it very challenging. But that's where that's where the focus of the effort is to try and be able to figure that out.
Right. Okay. Thank you. Next question. Have you seen a lot of patients with a toss salad issue? Many of the neuralgia pains together.
Yeah, I've seen that's sort of been a big motivation for me to really emphasize the point that although it's a helpful construct to think about typical and atypical facial pain, it's I resist thinking about a single category to define each patient's disease. I really have I've seen very complex patterns of facial pain. So certainly I've seen patients who have very distinct descriptions of pain at different dermatomes. So the V1 versus the V3, for example. In one, this is one patient I remember, is where you can have heat that worsens the pain and cold that improves the pain. But then in the V3 distribution, that the opposite pattern is true, where the cold improves the pain. So what that tells me is that there is the possibility of these very complex and mixed patterns emerging just based on how the brain is malfunctioning.
Great. Thank you. How often do your patients face insurance obstacles, and do you have any advice on how to navigate that?
It's a great question, and I'll be honest with you. I've, as I've started my practice here over the past year, I've seen a lot of patients with facial pain, but I've encouraged them to. I have not offered, or I've offered off-label treatments, but I've not been aggressive about pursuing off-label treatments, but rather have been working towards establishing a clinical trial that would enable us to do this, to recruit patients and do this without requiring insurance approval. I mean, the trade-off is that we're not there yet, and we don't have those trials enrolling, and there are going to be there's uncertainty about if and when the trial will get off the ground. But we're certainly it's a major priority for our entire department. And if we are not able to get it off the ground, or there's very specific inclusion criteria that would prevent you from enrolling, at that point, I'm certainly happy to help navigate the insurance issues and do whatever we can to get certain treatments approved off-label. But I don't have any specific strategies at this point.
Great, thanks. So what do you think is the future for neuromodulation?
I think it's there's very promising. I think there are understanding and recognition of the complexity in brain networks and how the brain works has continued to evolve. And certainly over the past 10 years, I've seen a major shift away from this idea that there's a single spot in the brain that's the cause of pain, but rather thinking about a more distributed explanation and thinking about the brain as a network. You hear that term a lot, of how pain is emanating from interactions across many different brain regions. So we are understanding, we are improving and evolving in our ability to understand how the brain works. And second is technology. It's amazing to see both in our non-clinical world and the clinical world how technology is exploding, both with certainly in our ability to understand complex information with artificial intelligence, but also feats of engineering that allow for something like focused ultrasound that can make treatments much safer for patients and accessible to more patients. So I think our job here, my job, is to try and bridge these two areas, the neuroscience and the neurotechnology and patients, and try to identify opportunities where we can make progress and work towards safer and effective treatments that can reach a wide range of patients.
All right, great. Have studies shown any effectiveness with neuromodulation in differentiation pain?
Yeah, deafferation pain, just like with anesthesia dolorosa, it was it was a focus of some of the earliest studies in neuromodulation in deep brain stimulation. And the general take is that, yeah, it's inconsistent results early, and the results don't hold up over time. We're trying to fix that.
Got it. Thank you. All right, and let's see. Got another question here. Why does the pain worsen with barometer pressure drop, winter start and summer start, as an example?
This is a really great question. This is the kind of thing that our current understanding of pain just doesn't know what to do with, right? So there's also, goes back to my earlier anecdotal example of a patient who had sort of different triggering factors at different parts of their face. And you also hear interaction, things like itch, right? So sometimes patients' pain involves itching, which, it's a described clinical phenomena. But all of these suggest to me that there's a process of the brain which involves interpreting these multiple streams of sensory information, whether it's pressure, touch, cold, heat, itch, pain. And all of them are getting integrated very early in the brain, and those messages coming through are ultimately being consolidated and interpreted, and they get passed along up into the higher order brain networks that ultimately generate experience. And it, depending on how that circuit and that process is dysfunctioning, you can have this multitude of presentations and multitude of triggering factors that they're so rare and so unique to each individual that when you go to someone who's looking at a textbook definition for what facial pain is, it's very difficult to understand and manage that. So I do think you need to start with a way to conceptualize these various symptoms and clinical manifestations within a unified framework. And we're not there yet, but that's something I'm certainly interested in working on.
Mm-hmm. Great.
I'll also share another. Actually, go ahead, and I can share that.
No, go ahead. No problem.
So another example I think about when is a very nice illustration of how complex pain is and how it can manifest in very surprising ways. So there's a published case report of this very, very bad injury that happened to a worker working at a construction site where they had a nail go through their boot when they were working, and they were in such intense pain. Their heart rate was through the roof. Their blood pressure was high. When he was wheeled to the emergency room, and immediately there was a lot of concern about his physical well-being because of how much pain he appeared to be in. But once they took off his boot, it became evident that he had suffered no physical harm. The nail had gone between his toes, and he was actually not physically injured. But the view of him seeing his foot inside a boot with the nail going through signaled to the brain that it had been very seriously injured. And that was sufficient to simulate and generate this experience of excruciating, intense pain. So that really is a very, very clear illustration of why Descartes' view of pain coming from the outside in is just part of the picture.
Yeah.
The atypical facial pain bucket of pain being generated internally and related to the expectations that the brain has about how its sensory detectors should be working, and how it can get confused when there are certain disruptions to those processes. I think that's sort of what ultimately is explaining this wide variability that you see clinically.
Yeah, very interesting. Thank you. Could you comment on implanted peripheral nerve stimulation?
Certainly, I think it is an option. It's certainly an option, and there are patients that seem to have some benefit, and there are some patients that don't. I do put it in the category of treatment options that are currently available, but they have variable outcomes, and it's unclear whether they have long-lasting success. But peripheral nerve stimulation is certainly less risky than stimulation that involves implanting electrodes in the brain or making lesions in the brain. So it can certainly be an early step, and we provide those services at Stanford. We're happy to help.
Great. Next question here. How long after a failed MVD with worsened pain and side effects would you consider these results permanent? When is it recommended to begin to consider other procedures such as these?
It is unclear how long the natural history of an individual who's experienced something like that. It's not clear because they're rare, and like I said, the particular changes are unique to that individual. But certainly, after a year, I would be even earlier, probably 6 months. If you have that benefit, I would start considering exploring other options that are available. And hopefully over time, as we come back, we think about the next year, the next 2 years, the next 5 years, our experience in deploying these personalized treatments will grow, and we're really hopeful that we'll have treatments we can offer for patients. And I don't think you have to wait past 6 months to start considering those. It's very clear how much suffering they cause.
Right. Is there a relationship between pre-existing trauma and depression and the development of atypical facial pain?
Certainly, I think one major factor that can predispose to the development of chronic pain is pre-existing comorbidities such as trauma and depression and other mood disorders as well. And that again just speaks to how each individual brain can have different vulnerabilities in developing pain syndromes. Certainly, there's each individual person has very different associations with what pain means, and what pain means not just for right now, but what pain means for the future. And there are certain experiences that the brain may have memories of that makes it very, very vulnerable and sensitive to having the experience of pain. And it can cause more suffering than an individual that doesn't have those memories and experiences. So certainly think that there's interactions there. But psychiatric conditions, mental health issues, past memories, and the sensory experience of pain.
Got it. Thank you. I think we have maybe a few more questions here. Just got to find it. Sorry. Okay. Are there any issues with neuromodulation if you have an inflammatory condition?
Certainly, it depends, but there are certain issues that can make an individual more prone to infection or poor wound healing, so on and so forth, that may make certain interventions like deep brain stimulation more risky than if you didn't have those conditions. So I don't, but this is where I do think it's important to also consider alternative treatment strategies that have less surgical risk. So the focused ultrasound, for example, may be something that that would be a favored option in that case. But again, these are theoretical. We are really thinking about developing treatment strategies that focus on the disease itself rather than the specific method. So it would be really, really powerful if we could come up with a understanding of each patient's disease at the level which would allow us to say, well, if we needed to do deep brain stimulation, this is what we would target. If we needed to do focused ultrasound, this is what we would target, right? So someone who had a particular risk or preferences that were specific towards one of the treatment modalities could take the other option.
And with neuromodulation, do you also treat with specific medications in addition?
That's an open question. I do think there's there's clearly evidence that there's interactions between pharmaceutical interventions and other forms of intervention. So for example, the placebo effect, which is a process where your brain's expectations of some treatment and some benefit, there's evidence showing that can be blocked by giving naloxone, which is a medication that can inhibit opioid transmission. So the interaction between neuromodulation and pharmaceutical manipulation is real, and I do think it's something to consider in the long run. Certainly one major goal would be to reduce opioid use, right? So that's a major motivation for pursuing treatments like this. However, there may be ways where efficacy only depends on an interaction between the two. And so in the long term, I do think it's not clear how that's going to pan out.
Great. All right. Well, that's all the time that we have for questions for today. Dr. Ramaiah, thank you so much. This is such an important topic, and we get questions on neuromodulation all the time. So thank you for your time.